A very good evening. A very good evening, guys. So, I am Dr. Ramyasri. I teach obstetrics and gynecology. So, today we are going to start with the MCQ sessions. So, clinical based MCQ sessions pertaining to obstetrics and gynecology. So, you can definitely, I'll be asking you questions. So, you can try answering it to it. And any point of time, if you're not able to understand something, feel free to ask me. Okay. So, let's start with the session. So I try to keep little more of clinical, not like probably not very easy, right? So a gravida 3 female with history of 2 prior second trimester abortions associated with history of painless cervical dilatation comes to you with level 2 USG. What is level 2 USG? You can answer in the comment box what is level 2 USG. Which was the below finding? What is the most appropriate management? So this is a history based question as well. You have a picture also, you have an image also to read along with that. So she is having 2 prior second trimester abortions. So when she has 2 prior second trimester abortion, that definitely tells us that she is having cervical. So what are you suspecting before anything? Very good evening to all of you. What are you suspecting when she has 2 prior second trimester abortions? Yes, I want an active participation. Yes, Madhura. So as she has 2 prior second trimester abortions, it mainly suggests that we are dealing with a cervical incompetence. Cervical incompetence. Another thing which I want you to know whenever we are doing questions is the approach to the question is very important. Probably a single question, a single answer, but I have so many things to tell you with each question. So that approach also will go through during these sessions and whatever I have. Excellent, Shiva Jyoti. So we are, and Kesarpu, very good. You are suspecting cervical incompetence. Next question I asked was, what does level 2 USG means? Now, can you tell me what is this image telling us? So in this image, you have the fetal head and this is the cervix. If you see in the cervix, the upper part of the cervix is open and the lower part is closed. The upper part of the cervix is open and the lower part is closed. So this is called as what type of cervix? It is the Y-shaped cervix. So the next question to you all is, what is the pattern of opening of cervix in cervical incompetence or preterm labor? What is the pattern of opening of the cervix in cervical incompetence or preterm labor? So the pattern of opening of the cervix in preterm labor or cervical incompetence is a competent os will look like T-shaped. Then when upper part is open and the lower part is closed, it will look like Y-shaped. Next, from above to below, it will get open, which will look like V-shaped. And then we have the bulging along with the shape, also bulging of membranes, that will be U-shaped. Excellent, VS. So it is TYVU shaped. TYVU shaped. Right. So you're all absolutely correct telling that the most appropriate management is put a stitch, and the most commonly applied stitch is apply the McDonald stitch. So this is a cervical incompetence with the opening of the cervix. So obviously you have to go for the apply McDonald stitch, right? Now in the same question, let me ask you one more question in the same only, okay? Same question, probably I've given cervix closed like a T shape and cervical length is cervix is closed. cervix closed, and cervical length around 3 centimeters. Then what will be your management? Three centimeters T shape. Now answer for this question. Everything same. Gravida 3 female with history of 2 prior second trimester abortion associated with history of painless cervical dilatation comes to you with level 2 USG. Level 2 USG is a targeted imaging for fetal anomalies. So usually you do level 2 USG at around 18 to 22 weeks. We also call it as anomaly scan. So which shows the below finding. No, instead of that, I'm telling cervix is 3 centimeters T-shaped. Most appropriate management. Does the answer change now? Administer progesterone, apply Fothergill's, apply McDonald, wait and watch. Excellent. Then you won't go for putting a stitch, because for putting a stitch, you have 3 indications. One is history indicated. Wonderful, guys. I'm really impressed the way you are all answering. Excellent. So the 3 indications for applying the stitch are history indicated. To apply a stitch, it's not only just 2 abortions. They should have 3 second trimester abortions or 3 preterm labors. So history indicated is when they are having more than or equal to 3 second trimester abortions or preterm labor, or USG indicated. So USG indicated is 1 previous second trimester abortion or preterm labor plus cervical length less than 2.5 centimeters. Cervical length less than 2.5 centimeters. Okay. As well, last is the rescue cerclage. Rescue cerclage is where the cervix is dilated and you're putting a stitch. You call it as a rescue cerclage. If I tell cervix is closed, cervix is 3 centimeters and T-shape, cervix length is not less than 2.5, so I cannot put a stitch. So I see many of you answering, then it will be administer progesterone. You're very appropriate by answering administering progesterone. As she has previous 2 preterm labors or previous 2 second trimester abortion, she carries the risk of preterm labor or second trimester abortion. So you can give prophylaxis or prevention for preterm labor progesterone. Okay, excellent. That's wonderful that you all answered A. What is Fothergill stitch? Fothergill stitch is for prolapse. It's the amputation of cervix followed by putting a stitch. That's for prolapse. It's none related to our obstetrics, right? So that was about this first question, right? Let's go to the next question. So here we learned TYVU and the indications for cerclage operation. That is history indicated, USG indicated, and rescue cerclage. Okay. Next question. A 31 weeks pregnant woman, on examination pallor present, hemoglobin is 8 gram per deciliter. What should be the management? Carbonyl iron tablet, ferrous sulfate, injection iron sucrose, blood transfusion. Ferrous sulfate is given free by the government. Carbonyl iron is the best oral preparation with least with least side effects, with least GI side effects. Okay. Right now I see many of you having the different answers. Okay, I would like to ask Ammu Durga. Why is it C, Ammu Durga? Ammu, do you have any reason why do you went for C? Injection iron sucrose. So it's a parenteral. I think the first answer I can rule out is blood transfusion. Let's not do blood transfusion at all because hemoglobin 8 is my moderate anemia, not an indication for blood transfusion. Blood transfusion is done when we have very severe anemia or severe anemia in the last 4 weeks. So what are the indications of blood transfusion? When we have very severe anemia according to ICMR, or when we have severe anemia in the last 4 weeks of pregnancy after 36 weeks. Okay. The answer here is injection iron sucrose. Now let's understand why injection iron sucrose is the management. Okay. Indications for parenteral therapy. See, it looks very simple question, but still we tossed here and there with the options. So that's how we all would have read the indications charts. So applying back them in the question is something which we have to learn. Okay. So the answer actually is C here. So I'm happy we have some of you answering C also. So let's understand. Parenteral may indications. When I tell what are the indications for parenteral, students start telling not tolerating oral therapy, malabsorption. So any intestinal resection or topical sprue, malabsorption syndromes, right? Non-compliant and last 10 weeks of pregnancy with anemia also. Okay. And in parenteral, we have outdated our iron sorbitol and iron dextrin. In trend is iron sucrose and ferric carboxy maltose. Ferric carboxy maltose is the dude, matlab full jalwa of ferric carboxy maltose is running now, FCM. I think you all also would have heard FCM. Now, why is this become a hero is iron sucrose is 200 milligrams injection, whereas ferric carboxy maltose is 1000 milligrams injection. Now, when I go with ferric carboxy maltose, one setting I have 1000 milligrams, but the iron sucrose every alternate day I should take almost 5 injections in order to get 1000 milligrams of iron, right? Okay, now coming back to our question. So you should ask me, why are we going with injection iron sucrose? I have the answer here. Last 10 weeks of pregnancy with anemia. Now, I would like to ask you why last 10 weeks of pregnancy with anemia, we are going parenteral therapy. Why not oral therapy? What rises the hemoglobin faster? What rises the hemoglobin faster? Is it oral or parenteral? Is it oral or parenteral? Come on. Excellent. So I get the same answer which I tend to know that I will get from students. So guys, usually whenever I see students, most of you, 95% of you have same answers. Especially we are all common in doing, we do the same mistakes. So many times I try to pick up those mistakes and tell you all so that you don't repeat those mistakes. So what rises the hemoglobin, oral or parenteral? Both rise hemoglobin at same rate. I repeat, both rise hemoglobin at same rate. Hemoglobin starts to, actually I kept that as a next question, so I'll just show it off so we finish it off. Hemoglobin rises, the hemoglobin rise is seen after how many weeks? 1 week, 3 weeks, 4 weeks, 6 weeks. So both rise hemoglobin at same rate, and hemoglobin starts to rise after 3 weeks at a rate of 0.8 to 1 gram per deciliter per week. At a rate of 0.8 to 1 gram per deciliter per week. Hemoglobin starts to rise after 3 weeks at a rate of 0.8 to 1 gram per deciliter per week. So both with oral and parenteral, hemoglobin rises at same rate. Now when both hemoglobin is rising at same rate with oral and parenteral, because absorption is anyway only 10%. We know that it's only the 10%. That's why we give so high dose. We give 100 milligrams, assuming that it is only 10% which is going to go. So I give the same dose. I give the with respect to that only the dose of the iron, right? So if the rise in hemoglobin is same with both parenteral and oral, then why last 10 weeks I am giving parenteral? The woman who didn't take iron tablets for the past 30 weeks, do you really think I can trust on her that she'll take in the last 10 weeks? Obviously no. Many of the Indian women we tend to see, like, you know, dropping to us with hemoglobin 4, hemoglobin 5 in labor, and then they land up in the failure and all. So I want to be reassured that I have given iron will rise. So I keep her in the hospital, inject the iron and send her home. So it's mainly for the compliance purpose. So the take home message is, it's mainly for the compliance purpose. We tend to give parenteral therapy when patient comes to you with anemia in the last 10 weeks. Okay. Now, depending on the question, your answer will keep changing. If the same question was somewhere around 21 weeks, then what will be your answer? It will be either carbonyl iron or ferrous sulfate. Ferrous sulfate is given free by the government. Okay. Normally, how much is the dose of iron which is given free by the government? So now we are following the Anemia Mukt Bharat. Guys, if you know, you have got a question on anemia, not you, I think, okay. There was a question on Anemia Mukt Bharat. So Anemia Mukt Bharat, how much is the dose is? Yes, anybody can answer. 60 milligrams of elemental iron for 180 days in pregnancy. This I'm only telling for pregnancy. You have different doses for teenagers and reproductive women, all those also. So 60 milligrams of elemental iron for 180 days in pregnancy and 180 days postpartum. That's about the Anemia Mukt Bharat. Yes, plus 500 micrograms of folic acid in the first trimester. This is starting from second trimester. Iron, you're going to start from the second trimester. It's not 100 milligrams. It is the 60 milligrams of elemental iron for Anemia Mukt Bharat. Okay. Right. Excellent, Sai Taruna. Very good. Let's go to the next question. A 27-year-old had blood pressure of 160/110 at 32 weeks of gestation. There is headache and blurring of vision, no proteinuria. Her blood pressure before pregnancy is 110/70. What is the diagnosis? Chronic hypertension, mild preeclampsia, severe preeclampsia, or gestational hypertension? Preeclampsia is again a very, 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 very important topic. Must. Okay, so I see the answers popping out. So as of now, I have D. I'll just underline all the options, whichever I get, okay? I have D, I have B, I have C, We don't see A option from anyone. So please don't answer A, okay? A is ruled out by all of you. So A is not the answer. Very good. That's cool. Now, I think I've given a very good question, because so many answers I'm able to get from the students. Most of you are answering D. Now, whoever are answering D, let's speak about all the definitions. Let's start with gestational hypertension itself. So gestational hypertension is blood pressure more than 140/90, blood pressure more than 140/90 after 20 weeks of gestation. Blood pressure more than 140/90 after 20 weeks of gestation. And blood pressure returns to normal within 12 weeks post-delivery. And there is no proteinuria. Yes, I believe you all answered it's gestational hypertension, suspecting that there is no proteinuria, right? But actually, let's see, you're actually a little off wrong. I'll tell you why. Now let's see preeclampsia. So preeclampsia is blood pressure more than 140/90 after 20 weeks of gestation. Is it plus proteinuria, or according to the recent guidelines, it is plus or minus proteinuria? Let me write it with red, so that it registers into your brain. So guys, what is the take home? What is the main purpose of these classes is, how many ever classes I'm doing to you all, you should do as many mistakes as possible. And every mistake, you should learn the mistake should teach you the right thing so deep that you will not commit that mistake in your exam. Okay? So if you do mistake, I'm happy actually, because that is going to help you more, that you're not going to commit it anymore. So preeclampsia means it is plus or minus proteinuria. Proteinuria is no more mandatory to call it as preeclampsia. Is that clear? Now why? In the absence of proteinuria, if we have any of the following findings, you don't require proteinuria at all. If you have these findings, even without proteinuria, you will call it as preeclampsia. So what are those findings? New onset of cerebral or visual disturbances, platelet count less than 1 lakh, raised creatinine, raised LFT. So what do you understand? Any organ failures, end organ failures, raised LFT, pulmonary edema. If you have any of them, you don't require proteinuria to call it as preeclampsia. Did it strike now why the answer is not D? Right. I have again one more point to speak in this. We again have a classification of mild and severe preeclampsia. Mild preeclampsia is blood pressure more than 140/90. Sorry, it's not 140/90. It is usually 150/100. Severe preeclampsia is usually diastolic blood pressure more than 110. Severe has signs and symptoms of end organ failure. Mild has no signs and symptoms of end organ failure. That is, all this headache and all won't be there in mild. Chronic hypertension is blood pressure before pregnancy or blood pressure after 20 weeks, but not coming back to normal within 12 weeks, right? So guys, let's go back to our question. Now you answer. I still don't see the correct answer actually. I want all of you giving the correct answer. So there is no proteinuria. 160, 110. There is headache and blurring of vision. What is this? This to be ruled out. Is it mild preeclampsia or severe preeclampsia or gestational hypertension? Yes, Gautam, what do you feel? Is it mild or severe? Don't answer A now because A is ruled out. Excellent. So I now see all of you answering correct. It is the severe preeclampsia. Why is it severe preeclampsia? Because the diastolic blood pressure is more than 110. The diastolic blood pressure is more than 110. And there is headache and blurring of vision. And as there is headache and blurring of vision, that is new onset of cerebral or visual disturbances. It goes for severe preeclampsia. Okay. And these are also called as this headache, blurring of vision are also called as impending signs of eclampsia. Whenever you have impending signs of eclampsia, immediate delivery. Now, this patient is 32 weeks. In spite of that, I'll do immediate delivery for her. Okay. So I repeat again, very good, Madhura. I'm happy that you're stressing that this is a C, guys, right? Yes, it's a C because they have headache and blurring of vision. As they have headache and blurring of vision. Okay. Okay, now, if there was no headache and blurring of vision, still it would have been severe only because blood pressure is 160, 110. Because blood pressure is 160, 110, but there should be proteinuria. See, if you have headache and blurring of vision, you don't require proteinuria. But if you don't have headache and blurring of vision, you should have proteinuria positive. So probably because you're little on a confusion about the definitions, in the coming exam, in the coming test, which I'll conduct again. So I try to give some more questions so that you have a clarity. So any confusion you have regarding this question, you can again ask me after I end the session. No, at the end of the session. So let me go to the next question now. Identify the cause for this. What is this? No, what might cause this? Gestational diabetes, diabetes before pregnancy, valproate medication, AC inhibitors medication. Do you know what is this called as? Where you have both legs joined together. Very good. This is called as cyanomelia. This is called cyanomelia. Yeah, I agree to all of you that this sacral AC inhibitors are contraindicated, but this is not because of AC inhibitors. So I again see a very good answer from somebody has answered. I don't know whether they VS. Very good, VS. This is the sacral agenesis. The better way of calling this is sacral agenesis, or it's also called as caudal regression syndrome. Gelpari, mermaid, both legs fused together to make it as a one. It looks like a mermaid, no? So that's the sacral agenesis or caudal regression syndrome. Can you tell me now, where do we see this caudal regression syndrome or sacral agenesis? Is it GDM or is it diabetes before pregnancy or is it valproate medication or is it AC inhibitor medication? If we have AC inhibitor medications, it will lead to renal stenosis. Okay. Valproate medication will lead to Contradi syndrome. No, that's warfarin, I'm sorry. Valproate medications mainly leads to cleft lip and cleft palate. GDM and diabetes before pregnancy. Which one you want to go? GDM or diabetes before pregnancy? So very good, VS. This is the diabetes before pregnancy. This is due to diabetes before pregnancy. So please remember, guys, the most common anomaly. This again, even in your dreams also you should answer. Matlab, if somebody, you're sleeping, somebody asks you in the middle of the night also you should answer. That means it should go so deep into your brains. I'll give you 3 single liners. Most common anomaly associated with over diabetes, diabetes before pregnancy is over diabetes, is VSD, more than neural tube defects. Okay, and most specific anomaly with over diabetes is caudal regression syndrome. Is caudal regression syndrome. And most specific cardiac anomaly is transposition of great arteries. I repeat again. Most common anomaly associated with over diabetes is VSD, more than neural tube defects. Most specific anomaly is caudal regression syndrome. Most specific cardiac anomaly is TGA. So this was the specific anomaly for over diabetes, which was shown to you in a picture. So this is the transposition, this is the sacral agenesis of caudal regression syndrome. This was NEET 2020 question. You know, many questions of NEET come to you and many questions of FMGE come to NEET. So there is a jumping of the questions. Actually, your question paper which you got in FMGE 2020, it was complete copy topics of NEET 2019. If you go back and see there was also vulval cancer question. There was also unicornuate uterus question. Even you people had those questions, right? Can GDM cause any anomalies? Can GDM cause anomalous fetus? Absolutely no. GDM never causes anomalous fetus. Why does GDM never causes anomalous fetus? Because GDM is usually, we tend to see GDM usually in the second trimester. It's mainly because of the increased anti-insulin hormones due to anti-insulin hormone production in pregnancy. So those anti-insulin hormones tend to be increased in the second trimester. As the anti-insulin hormones increase in the second trimester and organogenesis takes place in the first trimester, we don't tend to see anomalies in GDM. We don't tend to see anomalies in the GDM. Okay. Next question. A patient presents at 28 weeks with pain abdomen since 3 hours associated with decreased fetal movements, USG showing the following. FHR shows 90 beats per minute. What is the management? This is something similar to what you got in FMG 2020 paper, but I just framed it my own way. That's all. Okay, who will tell me what is this USG image telling you? Yeah, macrosomia can be seen with GDM. Gautam is asking me, can macrosomia be seen with GDM? Yes, macrosomia is seen with GDM. Guys, what do you see in this picture? Do you want me to maximize it, the USG picture? Just a second. Array, I should have not maximized, I guess. Okay, what do you see in this picture? So actually I have demarcations written in this. So this is the placenta and this is the retroplacental hemorrhage. So this is the blood getting accumulated behind the placenta. Guys, I don't want you to answer, tell me what is the answer, but I want you to answer what is this? Yes, what is the diagnosis for this name? What is the name of this? Placenta, and behind placenta you have blood accumulated. So many times USG images you can identify or answer with the help of question also. Okay. Very good, Sai Ratan. You're correct. This is early detachment. But what do you call the premature separation of placenta as? Can you give me the name? It's an abruption. What type of abruption is this? Concealed abruption. Concealed abruption. No. This is not placenta previa. This is concealed abruption. Very good, Renju. Very good, Renju. This is abruption. To be more precise, this is concealed abruption. Probably next class, I'll show you one image of placenta, one question on placenta previa with image. Placenta previa is placenta lying in the lower uterine segment. Abruption is premature separation of placenta. Abruption is premature separation of placenta. Okay. So as the placenta is separated, you tend to see blood behind the placenta, right? So this is a concealed abruption. You have a 28 weeks. That means it's premature baby, no lung maturity, right? She has pain abdomen since 3 hours. Now I'll tell you one point about abruption. You know, abruption is like, normally placenta should get separated in which trimester? Third trimester. But here the placenta gets separated before itself. So as the placenta gets separated before itself, Bichara uterus doesn't understand. So it thinks maybe it's the third trimester, and what does it do? Goes on continuously contracting to push everything outside. And what happens if placenta gets separated? Will you have blood flow to the oxygen flow to the fetus? No, it is the maternal blood which is transferring the oxygen to the fetus. So if there is abruption, it is definitely going to cause fetal distress to the baby. Right? Now, there are continuous contractions. So that contractions is going to cause her pain. There will be bleeding per vaginum. Painful bleeding per vaginum, it is abruption. Why am I stressing this much? Because you got a question on abruption in your FMGE 2020, right? So painful bleeding is due to abruption. Okay. Now what will happen to the fetus if you just wait and watch telling, no, it's a very preterm baby, I cannot remove this baby. If I don't remove this baby, what will happen? This separation of the placenta will go on extending and it will decrease the blood flow to the fetus. So obviously it will automatically decrease the oxygen supply and cause fetal distress. So what did you understand from all this? Will you wait in a patient of abruption, or will you deliver the patient of abruption? Will you immediately deliver or will you wait? I cannot wait. I have to deliver the patient of an abruption. If I wait, what will happen? Separation will go on continuing. Blood flow to the fetus is decreased. Bleeding will increase. Baby will die here. Mother will go into shock, and more blood gets accumulated. There is a risk of DIC. So we are putting both of them in the risk. So first and foremost, the most important is you have to do Pritchard. You have to go for immediate delivery. So we follow something called as Pritchard's rule. So Pritchard's rule is immediate delivery. Hematocrit should be maintained more than 30%. Urine output should be maintained 30 ml per hour. Okay. Now, what is the mode of delivery? That's also one of the biggest confusion. Many of you will tell cesarean section. No, uterus is in Josh to push the baby. It's going on contracting. It wants to push everything outside. So will you tell uterus, hey, Chup, I want to take you for cesarean? No, right? When it is in Josh, let it deliver, no? So let's understand. So your mode of delivery depends on fetal status. Fetal status. If fetus is dead, yes, if you diagnose it late, baby can be dead. If fetus is dead, check the maternal status. If mother is having DIC, correct the DIC. Anyway, baby is dead. First, correct the DIC. Correct DIC and then go for induction of labor or augmentation for vaginal delivery. Okay. If fetus is alive, if no fetal distress, induction of labor or augmentation of vaginal delivery, fetal distress is present, then cesarean section. Whenever you have fetal distress, you always have to go for cesarean section. Okay. Now let's go back to your question. You got a very similar question in FMGE 2020. I didn't want to give exact similar, but I wanted to teach you that concept here. So is the baby having distress? Absolutely, the baby is having distress, 90 beats per minute. Now, if I wait for steroids, baby can die. So what is the best thing I'll do? Immediate LSCS. What is the best thing I'll do? Immediate LSCS. Very good, Newful. I hope I'm pronouncing right. You're correct. A is the answer. Next question. A 40-year-old Gravida 2 para 0 with a booking BMI of 26. Is BMI of 26 normal? Is referred to high-risk antenatal clinic at 39 weeks of gestation because the midwife was concerned about her fundal height. An ultrasound assessment suggests an estimated fetal weight of 4.450 grams with amniotic fluid index of 90th centile. What is the management? What is the management? This entire story, I have only two important things. Based on these two important things, you can answer the question. So I just want you people to answer it. Okay, I'll wait for it. Very good, Taruni. So I see Taruni answering very well. Very good, Taruni. Taruni, can you substantiate why did you answer B? No, it's not immediate cesarean section. It is elective cesarean section. I don't have an emergency to go for cesarean section, but I want to go for cesarean section here. Okay. Who will tell me why are we going for cesarean section? Excellent. BMI 26 is overweight, not obesity, but overweight. Fetal weight of 4.450. What is that? Excellent, Madhubala. Very good, Madhubala. So 4.450. That is baby's weight is more. So baby weight is more suggests that we are dealing with macrosomia. We are dealing with macrosomia. So as it is a macrosomia, I would like to go for elective cesarean section. Elective cesarean section can be conducted after 39 weeks. Okay. And why macrosomia holds risk for shoulder dystocia? In India, macrosomia is more than 4 kgs. According to ACOG, Americans are little well built than us. For Americans, macrosomia is more than 4.5 kgs. See, there is one more reason why I am directly going for cesarean. 40-year-old nulliparous. She had a previous abortion. That's why para is 0. So I think for her, it's a precious pregnancy. So high risk antenatal clinic. So better when you have a microsomic fetus, just go for cesarean section for her. But it's not an emergency. I don't require. So probably if I would have given one more option of emergency, would have confused you. I don't require to rush take her for cesarean. I can go for elective cesarean on her. Okay, let's see the next question. A 40-year-old multiparous, all elderly women only, no, presents to the labor ward with a history of premature rupture of membranes at 29 weeks. Indeed, it is PROM. She complains of regular uterine contractions coming every 3 minutes. Speculum examination confirms rupture of membranes and her cervix to be 3 centimeters dilated. Clinically, there are no signs of chorioamnionitis. What should be her management? Now, guys, I wanted to alleviate the fear of clinical questions from you all. So that's the reason some questions, I think most questions I've given little like a story. PPROM, cervix 3 centimeters dilated, but she's 29 weeks. What do you want to do? Okay, I already see the answer, but I just wait for some more people to answer. So I'll quickly revise the management of PPROM. Okay. I'll quickly revise the PPROM. So PPROM may, whenever you have PPROM R or PROM, we take a high vaginal swab for group B streptococcus. Good, I see majority of you answering correct. So we take a high vaginal swab for group B streptococcus. Why? Because group B streptococcus can lead to neonatal sepsis. And whenever the patient goes to PROM or preterm labor, there is a risk of neonatal sepsis. Okay, so you have to take high vaginal swab for group B streptococcus, and you have to give antibiotics for rupture of membranes. You have to give antibiotics for rupture of membranes. So because there is a risk of infection in the mother also, risk of chorioamnionitis. The antibiotics which we give is tab erythromycin, 250 milligrams QID for 10 days. So the antibiotics which we give are tab erythromycin, 250 milligrams QID for 10 days. Okay. If the gestational age is more than 34 weeks, you can just deliver her because there's already lung maturity and everything is fine. So just deliver. If the gestational age of the patient is less than 34 weeks, lung maturity is not there, so I have to wait on her. She's having contractions, give her tocolysis. The tocolytic of choice is nifedipine. Give her steroids for lung maturity and give her magnesium sulfate for neuroprotection. These 3 things have to be given. Now, if you go back, the patient is 29 weeks, so she's less than 34 weeks. As she's less than 34 weeks, what is the best thing to do? Give her steroids, give her antibiotics plus inpatient monitoring for 48 to 72 hours. Absolutely correct. You all are correct in answering that. Answer is C. I think if the question would have given magnesium sulfate for neuroprotection also, would have been more better, right? What is the main contraindication for steroids? Chorioamnionitis, Cushing syndrome, diabetes mellitus, multiple pregnancy. What is the main contraindication for steroids? Chorioamnionitis, Cushing syndrome, diabetes mellitus, multiple pregnancy. Chorioamnionitis is absolute contraindication for steroids. Chorioamnionitis will flare up. With steroids, always the infections get flared up. Your infections flare up with steroids, right? Okay, let's go to the next question. A 36-year-old woman is complaining of having heavy menstrual bleeding for 2 years. Abdominal examination reveals 20-week sized uterus. Her pelvic scan shows multiple interstitial fibroids. Her hemoglobin is 9 gram per deciliter. She is nulliparous and wishes to preserve her fertility. She wants to preserve her fertility. She wants to get pregnant in future. What is the management option would you recommend? GnRH analog for 6 months followed by myomectomy, MRI focused ultrasonography, open or laparoscopic myomectomy, ulipristal acetate. So am I getting the answer of A and B for this question? I think it's for the previous question. Yes, what about this question? So first and foremost, that she is having symptomatic fibroid. Symptomatic fibroids, and there's not like one fibroid, there are a huge number of fibroids. Next, she is also having anemia. So what is the best thing to do for preserving her fertility? Excellent, Chakri Kumar. Very good. So the best thing, I want to preserve the uterus now. I want to preserve the uterus. So best is give her GnRH for 6 months. What is the advantage of giving GnRH for 6 months? When I give GnRH for 6 months, it will decrease the blood flow to the fibroids. So as it decreases the fibroid blood flow, it will shrink the size of the fibroids. As well, it will decrease the blood loss during the surgery. But there's one problem with this. When you give GnRH, the plane of operation is distorted. Okay. So the answer here is A. So you have to go for myomectomy. MRI focused ultrasonography is non-invasive method, but they don't preserve fertility. The chances of fertility are decreased post MRI focused ultrasonography. Better than open and laparoscopic myomectomy, I want you to tell GnRH analog followed by myomectomy to decrease the size of the fibroid and to decrease the blood loss during surgery. Ulipristal acetate acts well when you have a single fibroid less than 4 centimeters, then multiple fibroids. I think we can see one more question before we end the session. A 32-year-old Gravida 2 Para 1 Living 1 at 16 weeks of gestation presents with complaints of palpitation, nervousness, insomnia, and fatigue. On physical exam, a fine tremor is noted in her hand. Her heart rate is 120 beats per minute. What is the most likely diagnosis and what is the best treatment for her? So what is your diagnosis, guys? What is your diagnosis? What is your diagnosis? This is tremors, heart rate increasing, palpitation, nervousness, insomnia. All this is suggestive of hyperthyroidism. It's not physiological, it is hyperthyroidism. So hyperthyroidism at 16 weeks, what is the best management which you can give? So the management for hyperthyroidism is, first trimester, the drug of choice is propylthiouracil. In second and third trimesters, the drug of choice is methimazole. Now, as I don't have methimazole, I can go with the carbimazole. So that's why the answer here is C. Start on carbimazole. Propyl thiouracil is the drug of choice in the first trimester when because methimazole and carbimazole are little teratogenic. So we avoid giving them in the first trimester. But better control is with carbimazole and methimazole. So as she has come to you in second trimester, you can give her methimazole, actually methimazole. But as I don't have the option of methimazole, I'm going with carbimazole. Okay. I think this is the last question I have. Okay. Yeah. So I'll go to the last question. A 20-year-old with heavy bleeding per vaginum since 3 days comes to you. Hemoglobin is 6.5 gram per deciliter. What is the first test to be done in this case? TSH, UPT, TVS, progesterone challenge test. Okay, I think you have another class started. Okay. Right. So I think I'll end with this. So the answer here is UPT. Whenever you have heavy bleeding, always do UPT first. Always do UPT first because pregnancy complications are the one which has to be first ruled out. Okay. Right. I'll end with today because I think you are having another class starting. So before I end, a positive note and ending the class. So success consists of going from failure to failure without the loss of enthusiasm. So I just want you to be very positive and give yourself the best for this another 1 or 2 months which are left to you to get a definitely 200 out of 300. So I'll again see you in the next class, and probably in the next class we'll plan what can we do with every session so that we can take a maximum benefit of these sessions. So as you have another class started, thank you guys, all the best, keep studying. Thank you.